Hello, my name is Hans
Johanness
Huitink. I'm
Huitink.
an anesthesiologist from the Netherlands, or I would rather say anesthetist from the Netherlands. And the topic today is airway management and anesthesia and non-operating room situations. A very interesting topic, I think. And I'm based in the Netherlands. And as you can see, we live with many people in a small country, so we light up the whole universe at night. Some consider me an airway management expert, and this is why I can spell out my first name with the airway devices. You can find me on Twitter, Airway MX Academy, if you want to follow interesting airway management conversations. What is my non-operating room experience? I work in a mobile intensive care unit in pre-hospital environment, sometimes in the emergency room to do large trauma cases. I have extensive critical care experience and also retrieval with the air ambulance and procedural sedation. So I've done this for the last 25 years in my work as an anesthetist. What skills do we need to possess to provide safe airway management and anesthesia outside the operating room? A very great example of this was shown a couple of years ago when the boys from the football team were rescued from the cave in Thailand. This operation was supervised and developed by an anaesthetist from Australia. So this is a great example of airway management and anesthesia in very extreme non-operating room conditions. The first question: which book can I read and which course can I attend to learn all this great stuff? Here's the problem. I think you need gray hair, so wrinkles. This old wise guy has experience. And he can sail with his sailing boat through the storm in a Volvo ocean race and probably do a surgical airway because he has learned this in his career. The thing is, if you start as a junior doctor, how can we learn all these great skills? Because it's not so easy, because the transfer of knowledge and skills of the experienced to the less experienced is of paramount importance, but difficult in these conditions because it's not in books and it's never the same. So let me tell you my learning objective for this talk. I would like to provide you some learning format based on my own experience of 25 years in anesthesia outside the operating room. If you look at these situations, you may end up as a medic or doctor during a Mount Everest expedition, which is cool. Or work in a mobile intensive care unit, work in wilderness medicine, or on board a large cruise ship, do sedations in the CT scan, fly helicopters. Cool stuff we have. And all these situations have in common that you work in a kind of hostile environment. Nothing is the same as you know it. It's noisy, temperatures can change, sometimes it's really dangerous. It's often remote. There's no immediate help available and no extra equipment if you don't bring it. You work in small teams in a confined space and you don't have access to a laboratory if needed. So this is different from the operating rooms. Let me take you to Bonaire, a great Caribbean island. It's Dutch province. I worked there in 2011. If you work as an anesthetist on these small islands, you have a big problem. It's not the people from the island, it's the ships. Every ship has 3 to 4, even 6,000 passengers on board, and they bring patients to you. You would take one with the ambulance to the hospital. But if this is your tropical hospital, this was the situation in 2011, and there's only 2 of you, and one nurse, anesthetist, a surgeon, a gynecologist, and a cardiologist is never there when you need him because he's only there every 14 days, and there are some general practitioners. You need to improvise, and you will do a lot outside the operating room. It has 36 beds, 1 operating room, but no ICU, no CT scan, 1 X-ray machine, 1 extra ventilator, no flex scope, no video laryngoscope, and also no ENT surgeon. This is me doing some underwater airway management back then. It's great diving. But as you can see, even on a small island, you will have patients in all kinds of sizes, and you need to do air ambulance flights in planes to the other islands or a higher level of care. And if this is your emergency room and this is your equipment, you need to improvise. And you can have these patients because traffic accidents occur everywhere. Although with a low frequency, it will happen. You are the doctor, you need to improvise. And people don't wear helmets and have a very great motorcycle, as you can see. You can go diving, and if you exit the water, you may exit live. And this is what happened to a patient I had to resuscitate on Little Bonaire. And as you can see, this is a little island outside and offshore. So I needed to jump into a police boat, go with the boat to the island, bring equipment, jump into seawater, resuscitate on the beach. And it was a diver, a young guy who drowned during diving. And if you need to intubate and you take a video radioscope, this is what you will see. There's bright light everywhere. It's a white beach, sunny day. You don't see anything. This is not what we normally do in the operating room. This is hardly ever a problem. So if we look at airways closer, we need to triage airways and find a way to solve these problems. I rather speak about basic and advanced airways and not easy or difficult airways because it's very subjective. A basic airway, my definition for a basic airway, is that it can be managed with basic techniques by a trained person. And airway rescue is most likely possible because the patient still has a normal anatomy of the neck, by definition. Advanced airways, in contrast, may require techniques that are not often used, and these patients should be managed by a team that has special skills or special airway devices. This is the method we use for airway triage app. You can download it on the App Store if you want. Outside the operating room, most airways will be advanced, but there is a difference between low advanced and high advanced, high complex advanced. Look at complexity factors. Which factors can make this airway management procedure really complicated? The context and complexity factors determine what kind of help is needed or what you need to do. And this is a good way to look at situations outside the operating room. Outside the operating room, things may be totally abnormal, atypical, extraordinary, out of the ordinary, noisy, dark, chaotic. It's just never the same. This makes it really interesting to work, but also really challenging. And in these non-operating room cases, it is good to look at complexity because these complexity factors can predict the risk of complications. And it will be necessary to adapt airway management and anesthesia to the context. It will never be the same. And you have to ask yourself a question. Do I need to treat the patient here and do I have to do this now? A very important question. If we define triage or airway triage, you could define it as follows: do I have the appropriate technical and non-technical skills, experience, team, time, budget and equipment for risk stratification and manage this airway safely? And do we have to do this here and now? So triage is a very important point if you work outside the operating room. This is airway management outside the operating room. This was a guy who had out of hospital cardiac arrest, came to the hospital, we intubated, and then we had a problem because there was no ICU on Bonaire and we had to fly him to another country in South America. I think it was Colombia. If you transport a patient outside the country, you will need a passport. But if you're old and never travel, you don't have a passport. So this was fixed in this way. He was not able to sign, as you can see. They took a photograph, printed the passport. We brought him to the air ambulance and he was transported safely. This is rather extraordinary. Check complexity factors in 6 domains. There are 6 domains you have to look at. First, human factors. If you are tired, you are quite dangerous. So if you are tired, tell the team you're tired. Or if there's a language problem or language barrier, tell the others you don't understand what they're asking you. And look at your own experience. Do you have enough experience to do the job? And look at the location. Where am I? It makes a big difference if you intubate a patient in the CT scan or in the operating room, because there's no extra equipment. They lie flat on the back. So you rather go to the operating room if possible. Patient factors are really, really important. Anatomy, physiology. Equipment, what kind of equipment do we have, and is it any time pressure? These 6 domains, HELP-ET, H-A-L-P-E-T, can predict if situations or airway management can be challenging. Let's look at it more closely. If we have a patient with airway obstruction and we look at the 6 domains, it can be 9 o'clock in the morning, 9 a.m. You may have a very experienced team. If you fly with a helicopter, it can be at the roadside, and if there's a bleeding in the airway with a high BMI, and also problems in the mouth and a low saturation and low blood pressure, you can classify this airway as very highly complex advanced, because there are multiple factors and 5 domains. The situation may change dramatically if it's 4 at night, if you are tired, or inexperienced, and if the blood pressure is very high. So every situation will be different, and you need to assess the situation again and again, because this will predict the assistance you will need or the risk of complications. The total number of factors and the weight factor and the complexity in multiple domains increase the risk of complications. Remember this: the total number and how many domains. This is available in Airway Triage app. This will help you with the smart algorithm if you want to do this. It's probably the most reliable airway assessment method. It's common sense. It's always with you on the phone. If you're forced to act, if there's no time, just start CPR. Do the best you can. You can't train for this. You just do what is needed. But if you have more than 60 seconds of time, do the HELP-ET checklist. If there's an elective case outside the operating room, the phase checklist. Just check the domains, make an airway strategy, and do it safe. So this is the airway triage method. If we look at locations, it can be really unusual. At the roadside, you may work at a field hospital. If you work in the military, you can work in a helicopter boat, MRI scan, or the patient ward. There are so many variations. The personal situation may change all the time. You may be tired, unskilled, understaffed, unfamiliar with all the other personnel in different locations, or feel inexperienced. Then often you will not have the correct experience because the situation can be really different all the time. This makes it really challenging, but also very, very interesting to work. If you look at environment, there may be a tsunami, a hurricane, a bushfire, a war, or flooding. And I'll show another example. When I worked as an anesthetist in Amsterdam, this was my academic center. It's a large tertiary university medical center in Amsterdam. Well, I was on call at night, and I got a call 2015. Do not start up all the operating rooms, the theaters, because there is a big flooding going on. What happened? A large water drain broke, the pipeline broke, and the whole hospital flooded. You can see it here in the stairways. We had to evacuate the whole hospital immediately. And this was the level of the water, and the whole basement of the hospital flooded at once. We called in the military, many ambulances came, and this was all done with anesthesia, with all the intensivists, with all the nurses, and we had to adapt and make a plan, and we worked outside the operating room. An example of anesthesia outside the normal working space. We also may have unusual patients, very premature or very heavy or aggressive, or there may be a lot of numbers if you go to a football stadium or a rock concert as a medical provider. There may be large numbers of patients. And then another question. Is it unusual for an anesthetist to end up in a non-operating room situation? I think the answer is no. I don't have a really extraordinary job. I work as an anesthetist. I've worked in multiple countries in different centers. But you will end up in a non-operating room situation when you work clinically all the time. So this is what we normally do. This is our job. And this is cool. We can bring patients to air ambulances or get them into the air or even fly in the plane. So this is what we do as anesthetists all the time. Or fly HEMS and go to trauma patients. Helicopter emergency medical service. Another great example of anesthesia now. And the good thing here is these are very highly trained teams. And if you look at it closer, the training is really important. You work with the same team members and they know each other very well. They possess technical skills, but also non-technical skills. And they are trained in CRM and situational awareness. And they do a lot of simulation, team training. And they can work under time pressure. And often these are experienced staff. And they learn from each other by case-based discussions. That's why I share my experience now with you in this webinar. Case-based discussions are really important because if you recognize situations, you will remember it and you can solve the next case if you see it. So this is the common factor for all these teams working outside the operating room. They are highly trained, and this is extremely important. You need to train really well. Another example. When I joined the HEMS team at the UMC because I was going to Bonaire, the Caribbean island, there was a call of a 26-week premature baby. It was a home birth, paramedics were called, the ambulance came, but they could not intubate. They could only back mass ventilate. And this was a really premature kid, 26 weeks, it's about 500 grams. What to do? We had a rendezvous with the ambulance. They transferred the baby, we jumped into the helicopter and flew, and we had a rendezvous. And what we saw when we came to the patient was a blue premature baby. We could not measure any SpO2. Breath sounds were really difficult to hear because the lungs are immature and very stiff. There was no heart rate detectable because the kid was in a plastic bag for the temperature regulation, and we had no IV access. Because we were with two anesthetists at that day, because I was joining the team because I had to move to Bonaire, we were able to intubate. We used the defibrillator pads on the kid to detect heart rhythm, and then we transferred the kid to a pediatric hospital. This was just a very improvised case, and because we were lucky there were two specialists, we could manage this really unusual case. A really tiny baby, 500 grams. Difficult to intubate as well. Very advanced, highly complex airway and situation, but we managed. So better be prepared. You have to be lucky some days. Non-operating room situations are common. It's context sensitive, and context sensitive anesthesia and triage are required to manage these cases. And this is difficult to learn from a book. I think you need to find a mentor, you need clinical exposure, and training is required, and then you can do well. This is great work outside the operating room, but training is very important, and see how others do it. Let's go back to Bonaire then. Beautiful island, the sailboats and the sunset. There was another case, the chicken bone history. I was on call, 11 at night. A boy came in with his father. He was 8 years old, and he had just had dinner at Kentucky Fried Chicken. He swallowed a chicken bone, had a hoarse voice, and was coughing, but there was no ENT surgeon. I did not have a flexible scope, and I did not know if this bone was in the airway or esophagus. And there was no air ambulance at night, so how would you solve this case if you are the anesthetist on a tropical island at night. I tried to call for help. I called an ENT surgeon on the other island, and we took an image, a radiograph of the neck, and I really could not see the bone, and I could not see if the bone was in the airway or esophagus. So I thought, okay, let's transfer this image to VUMC, the Academic Center in Amsterdam. There's always a radiologist on call, and I mailed I called the radiologist and said, okay, I'll send the photograph to you, and please, I have to know if this bone is it wedged in the airway and the esophagus. It makes a big difference in management of the case. This is the email I wrote in 2011. Please let me know, is this bone wedged into the airway or esophagus? And the answer was, I cannot see it. I really don't know. So there we are in the middle of the night, and the boy was stable. What to do? I decided to go home. I could not imagine and keep the boy at the hospital and return in the morning and make a plan and try to ambulance the boy to another island with a better hospital. When I came back in the morning, they already had medevaced this little guy to Curacao, because the pilot started early. They did not notify me, and they had just sent the boy to Curacao. And they said, "Oh wow, this is dangerous. Why did you do it?" That they said to me, "This is because we always do it this way." So I called the ENT surgeon in Curacao and said, "Okay, this is what happened. I hope the boy arrives safely, and maybe you can take him to the operating theater and see if the bone is wedged into the airway or esophagus." I called him, and he said to me, "The boy is fine." And I asked him, "How did you manage?" This is what he said to me. Because the boy came from a neighboring island, they have a protocol for infection. They do throat swabs, MRSA swabs, and then the nurse came, stuck this thing in the mouth, and the chicken bone came out. And this is how non-operating room anesthesia and airway management can be done. It's just fascinating all the time, and sometimes the solution is very easy and very simple, so keep it simple. This was one of my weirdest airway management cases, I must confess. So non-operating room clinical situations can occur everywhere. Be prepared, personalized in your anesthesia, and if you're interested, find a mentor who can learn you this and go out of the operating room. It's a great environment, I can tell you. It's really great to work outside the operating room. If there's any questions, I'm happy to answer by mail. This is my email contact, and again, my Twitter contact. Thank you very much for your attention, and thank you for any questions you have. Bye bye.
Thank you very much, Hans. That was fabulous. That was fantastic.